couple. I've been tied up in lots of meetings with Royal Free, but really nice to see everyone, and hope that people got a chance to have a bit of a break over the bank holiday weekend. I know tons of you were vaccinating, and really thank you for doing the vaccinations. In terms of NCL, not Barnet specific, but in terms of NCL, we hit a huge milestone over the weekend where we vaccinated over 1 million people. So that's absolutely terrific. So, you know, if you were asked anyone 6 months ago, could you since mid-December give 1 million vaccinations in NCL, would have said unlikely, but we've actually risen to the challenge, and that's a huge part of the efforts in primary care. And really thanks to everyone, because as I say, if it's not you specifically doing the vaccinating, you're probably supporting someone else in your practice, or doing the phone calls, or doing something to really support this mammoth effort, which is hopefully a huge part of the solution to COVID. So really nice to see everyone. In terms of update from CCG, so we are ploughing on in terms of recovery and what our expectations are for recovery. So there are virtually no COVID patients. I think I haven't heard from this week, but last week I think there was only one COVID patient that was in North Mid Hospital, so that was in NCL. So that's really, really good news. So in terms of resetting up services, re-getting going, that's a huge source of interest to all of us. And just thought I'd just very briefly highlight where we are. So in terms of TQuest, so in terms of phlebotomy, all the services, Royal Free, Barnet, Edgware and Finchley are open. In terms of radiology, SK ultrasounds reopened via TQuest, so that's at Edgware, Royal Free and Barnet. And the waits are about 6 to 7 weeks. In terms of in-health, there's a quicker wait of either 5 weeks in Golders Green, or if you've got patients who are willing to travel to Waterloo, it's 3 to 5 weeks, which is earlier. X-ray is 5 days, which is everywhere apart from Finchley Memorial that's reopened. The Finchley Memorial access for X-ray is only for the walk-in centre. In terms of spirometry, that's something that we haven't restarted. It's not started across primary, secondary or community. We can't restart it because it's an aerosol generating procedure, and until June we're not able to. What we're aiming to do is some training on how to restart it in June. Alongside the respiratory side of things, there's an exciting bid that's been put in with Barnet Hospital to enable Pheno, the testing for in terms of reversibility and asthma. To have the testing being done in primary care. So we're looking to see if we can get a bid to support that. So that's a really brief highlight and skip through where we are, but hopefully you'll find it's getting less difficult. I know over the weeks and months, it's been really, really hard knowing where to access things, but it does appear to be getting back to normal. And we're just hugely hoping that the system is modelling what to do if there's a third wave into the July, August time, but we're really hoping that that's not going to happen because of the vaccination. And certainly if there are more people going to hospital, hopefully it wouldn't be in ITU, it would be more in the general beds, and it would have less impact on the system, but we have yet to see. But we've been resilient and we've been holding patients. We know that's difficult, and we know that it's been hard for them and it's hard for us. So hopefully we are on the brink of it getting easier. So thank you for your patience with that. In terms of today, really exciting actually that we are dedicating this to supporting care homes. So we know we're one of the areas that have got more care homes than anywhere else in the country. And it was a huge gap in Barnet for a long time, having care home support really that our care home residents deserved. And that was pre-COVID, and we'd looked for a long time at doing it, and there just was no funding. We were in deficit for nearly all the time we were a single CCG, and there was no funding to be able to dedicate to this really important piece of work. But actually in COVID, what changed was the huge spotlight on the fact that care homes weren't supported, not just here in Barnet or NCL, but nationally, and a huge spotlight on that, and then the focus of NHS England to say that every area had to have a care home support team. And with that came that we had to do it. And because we were a merged CCG, finding that funding was a bit easier than it was had we been a single CCG. So I think that was actually a huge success of being part of a merged CCG by the time COVID hit. So really pleased that we've got the care home team. So we've got an LCS, so we've got 820,000 being spent on the LCS, so that's over £750,000 going to support the system, which includes primary care to support the residents in care homes. I'm really pleased today that we're joined by Dr David Levy, who I know lots of you know, who's one of the elderly care consultants from Barnet, and Louise Gacquin, I hope I pronounced your name correctly. So she's a clinical lead for the care homes team. So there'll be leading discussions on how it's working, the care homes ward rounds, as well as providing us with an update on the MDTs that are taking place across the PCNs. And I know a huge number of you are involved with that. So we'll be really interested to hear your perspectives. We'll be discussing some interesting cases from the local care homes, and also joined by a community matron from the care home team who will talk us through their role in the ward rounds. So I hope this will be really useful, and not just for GPs. I think on here are some nurses and other healthcare professionals. So welcome to all of you, and really look forward to hearing us being illuminated about where we've got to in Barnet, which is certainly really better than we've ever been in the past in terms of support to care homes. So in terms of our Federation training updates, we're going to have an update from Leah Withers, who's a medical education fellow, who's going to advise us on medical student opportunities in Barnet. So, but I think actually first I'm handing over to Anuj, who's going to give a Federation update. So thank you everyone, and over to Anuj.
Thanks, Charlotte. I don't know if the slides are available. I'll quickly run through the slides, but thank you. Thanks, Charlotte. I thought I'd give a brief update on the Federation services. So the first bit was around the EHS, which for the practices that are currently signed up for the Federation doing this, you can contact us on that email. The anticoag service, if you have patients who require any monitoring or advice, please do come back to us. It's run from 4 sites across Barnet and led by our pharmacy team. Next slide. So the new services, there's a GP support service to the rapid response team, which has been running now since January and has been really positively met by both CLCH and by general practice. It's going to go on till the end of June, and we're looking at discussions around longer term arrangements and trying to sort out that pathway really, and trying to make it as streamlined as possible for patients. The in-hours remote GP services, so if any practices need cover, either due to sickness or any other cover, we can certainly provide any cover to membership practices with GP sessions, usually that are remote, but please get in touch with us if you do need any GP services. Next slide. An update on the EAS. So I'm going to just briefly say that we are in discussion with the PCN CDs around trying to refine really the EAS service and practice data, and there's a task and finish group involving the CDs and practice managers. But in terms of a quick update, I was going to hand over quickly to Ray, just in terms of booking. I know that there were questions around how do you book, what time do appointments get open. So I'm going to briefly hand over to Ray, just very briefly tell you about that. Ray, do you want to come in?
Thanks, Anuj. So a bit more detail on EAS appointments. There's a combination of practice, 111 and patient bookable slots. The appointments for practices are embargoed and then lifted up in 2 tranches at 10 AM and 3 PM on weekdays. A handful of these appointments are kept by the call centre, which open up at 6:30, as well as a handful for 111. In terms of the appointments, these are profiled for seasonal variation, so hence why the
Ray, I think we lost
you, Ray. Yeah. I think if we go to the next slide, that will just give you a little bit on the seasonal variation. So although we get 48,000 appointments over the year, we tend to plan to allow extra capacity, particularly over winter. So the numbers of appointments in April, May, June, as you can see, the projected drop down a little bit. Now we are discussing this with our CCG colleagues to look at whether we can offer some more capacity for our practices, particularly because business as usual as well as COVID. So April went very much to plan, but as Ray was saying, 111 currently, particularly on weekends, use quite a lot of capacity, And again, we're trying to negotiate with the commissioners around how 111 access those, and these are really appointments that we want to reserve for practices as much as possible, really. So that was a little bit on the EAS activity. Just the last slide was just a quick reminder around the Looking After You Too project, which some of you may know about, but it's a service provided by NHS England around coaching support to colleagues, and this is all level of colleagues in primary care, from your receptionists all the way up to the partners. And it's an excellent service that is completely confidential and is around for another year. So if you do want to or are interested, please do visit the website, because it's really great support, and it can discuss clinical and non-clinical matters. So please do access it if you need. I think that's it. Anisha, can I hand back to you? Thanks very much.
Brilliant. Thanks very much, Anuj. So just a quick Training Hub update then before we hand over to David and Louise. So we can start with some good news. So we're delighted to welcome Dr David Levy from the Millway Medical Practice to the Training Hub team in his role as Joint Federation and Training Hub Director across Barnet. So I think we'll all agree that this is a very exciting thing for Barnet, and I'm sure Thiv will add huge amounts of value to this role. And we look forward to further collaboration between the Training Hub and the Federation. So huge congratulations to Thiv. Also, just to let everybody know that there is a multi-professional learning event being organised by Dr Joe Fernandez, who's one of our fellows at the Training Hub, just to focus on multi-professional learning. Now, as some of you may or may not know, Health Education England, HE, are really strong believers that multi-professional team working delivers better outcomes for patients and more satisfying work for clinicians. And as you know, teams are growing and teams are becoming more multi-professional. So it's really important that we, as doctors or whatever role we are, embrace the fact that we will be working with these colleagues in the future. This is the future of general practice, and we need to be good at supervising them and working together with them. So this event is really to address that. I'm sure it'd be hugely helpful. The afternoon will start with a session from award-winning writer, GP and educator, Dr John Lorna, who I'm sure most of you know. And he always stimulates lots of really interesting discussion. So that's on multi-professional supervision. That's on the 8th of June, 1:30 to 6:30. I'm going to post a link in the chat to the Training Hub website that has more information on that event. So if you'd like to know more, please visit that link. I'd now like to hand over to Leah, Dr Leatrice Withers, who's going to give us a quick update on some medical student teaching opportunities in Barnet. Thank you, Leah.
Hello, I'm Leatrice Withers. I'm a GP working in Pan Barnet Surgery, and I'm one of the medical education fellows for Barnet. I have 3 minutes to tell you about some opportunities to teach medical students in primary care across Barnet. So what's involved, there's lots of different opportunities, particularly working with UCL, one of our local medical schools, to host a small group of medical students at your practice. The opportunities range from hosting first years all the way up to 50 years and across lots of different themes, and from general medicine, elderly care, mental health, dermatology. You can see sort of a lot of the opportunities on the slides. And the opportunities range from having students that come to your practice for just one session and then never come back again, to having students that come back across a whole academic year, so you get to know them and get to watch them learn and develop. So there's a lot of benefits from getting involved, so it's usually highly recommended by those who've already gotten involved, and it often involves a chance to follow up a group of students in their development through a whole year at regular intervals. I found it quite rewarding to watch them grow in their skills and confidence. It's a really good way to keep up with current clinical knowledge, and obviously any learning from teaching the students counts towards CPD hours. I think I found myself that a portfolio career quite breaks up all the clinical working week. It can be quite good for the CV. You can see on the screen you get paid for teaching dependent on how big the group of students is, and actually it requires minimal input from yourself. You're more of a sort of supervisor. The students often provide their own presentations themselves, and they mostly just want to speak to to patients. So once you've recruited some patients, that's pretty much it from input. And there's obviously benefits to the practice too. So patients really enjoy speaking to students. Students often have longer appointments, so you can book in some complex patients, and the students can take a long time to go through the issues. You can get them to do home visits, diabetic foot checks, so there's an element of service provision to the practice as well. And it's also an opportunity to positively influence the perspective of the next generation of doctors about general practice. You know, some of us will have been inspired by a really awesome medical student placement in general practice to become GPs. So there's obviously benefits to yourselves, there's benefits to the practice. If you do want to get involved, I'll pop the email address you can contact at UCL to get involved or to find out a bit more information. If you have any questions, do feel free to contact me. I'll pop my email address in the chat as well. And there's actually a virtual event tomorrow evening, that's Thursday 6th of May at 8 p.m, where there's a panel from UCL and people who are currently teaching medical students in primary care, where we can answer some of the common questions and have a bit more of a discussion. So I'll put the link, the email address for Sonia Shah, who's sending out the link to this event, in the chat as well, so you can get in touch with her if you're interested. Thank you.
Thank you, Leah. I'm sure there's lots of people out there who want to get involved with medical student teaching, so that was really useful to hear. Thank you. Okay, so I'm very happy now to hand over to Dr David Levy, consultant geriatrician from Barnet, Louise, who is our clinical lead for the Gacquin project, and Kim, our community matron. Thanks to you all for joining us.
Hi everyone, I'll just share my slides. So hopefully you can all see that now.
Yeah, we can.
Yeah,
thank you.
Great. So thanks everyone for having us join your event today. So my name's Louise Gacquin and I am the clinical lead for the care home team. I just want to introduce Kim, who is our community matron, one of our community matrons. Dr Levy and Dr Romain are our geriatricians, and Dr Gold, who's our older age psychiatrist. So they are all here and will all be speaking at some point. So today we're just going to talk about our Barnet Care Home MDT. So it'll be quite brief, try and keep it as informal, so if anyone has any questions, just let us know. So firstly, we'll just talk about sort of the context in which we're working in, some of the key principles, the service model, the current MDT process, our caseload, and some of the challenges we faced in setting up and ongoing. And then I will hand over to Dr Levy, Dr Romain and Dr Gold to discuss the case studies, which will be far more exciting than this. And then Kim will finish us off with a discussion about his experiences on joining the GP ward rounds. So yeah, the context. So we have, as everybody already knows, we've got a large number of care homes in the borough. 91 with a bed capacity of about 2,490, give or take. This is loosely broken up into 23 nursing homes, 16 mental health, 25 LD and 27 residential homes. And information from LAS from 2019 to 2020 showed that the borough had the highest number of incidents of any of the 32 CCGs. And 1 in 5 of these were not actually sent to hospital. So the key principles, so I'm sure most of you are already aware, but the One Care Home team started in May 2020, and we started off the back of the COVID-19 pandemic. So we started initially with 14 care homes and 4 matrons, and since then we've grown. Our aim really is to deliver a community-based proactive healthcare offer to care homes, and ultimately to improve outcomes and address the inequity of service provision. In September, we set up our MDT, and we wanted to have an MDT that functions as one to provide specialist care to address the needs of the care home population, enabling quicker and more appropriate access to specialists rather than the traditional hospital referral route, which we know isn't always best and suitable for this type of frail elderly patients. So yeah, like I said, we've been operational since the 22nd of September with psychiatry support, and our geriatricians came on board in November. We have a twice weekly MDT which runs for 2 hours every Tuesday and Thursday. So there's been lots of discussions about what an MDT is, and every MDT is different. For our MDT, our core members are our MDT coordinators, so we have an assigned community matron who coordinates the whole process. Our geriatrician, psychiatrist and community matron. And then our optional members are our care home managers. So just a point on this is we're really trying to emphasise that the care home manager should be best placed to discuss this resident or even join the discussion and really add additional information on what matters most to the resident, as they often have the most information on them. And then we have the GP, so it's not mandatory that the GP for the care home joins. It is optional, so if they would prefer, that would be great, and if they don't, equally we'll try and get all the information without them. Then obviously we have the wider healthcare professionals. If we need, we can invite them. So as a community trust, we have in-links with dietitian, physio, we have a physio and OT on the team, and we also work quite closely with the CCG pharmacist. So depending on the need, we'll invite optional members depending on the presentation. So just a little bit about the model. So I did lots and lots of work just before we started, looking at different models, trying to replicate ones that worked. And I think what I came to in the end was that no single model fits. So I think you have to build one based on the needs of the population, the needs of the GPs, care home managers. So we don't have a defined model, but we have an ops policy that we work towards. So just our total activity to date. So we have been tracking our activity. Initially it was slow, and as of the end of last month, we've had a total of 129 residents referred, and we've discharged 82. So just to run through the process, just so everyone has an idea of it, from when, I'll just briefly do it, from when the resident is referred. So a care home manager can refer a GP or the community matron. So for example, they identify a resident in a care home that meets the criteria, and they'll refer to our MDT coordinator. So either our coordinator or the community matron will gather all the information, and usually the coordinator will send out the invites. So if the GP would like to attend, they'll be sent an invite ahead of time. During the meeting, the case discussion will happen, and we will usually try to use the 5M model, which I'll talk about on the next slide. And then once we've had the discussion, we'll make a decision on when to bring them back, which is just generally a discussion on when is the most suitable. So if we've put an intervention in place or reduced a medication or started something, then it'll be dependent on that. And then the feedback. So obviously we want to make sure that all key people are involved and informed of what's going on with the residents. So the care home manager and GP, if they've not been in attendance, it'll either be verbally communicated or via an email by the matron or the MDT coordinator. And then once the resident has been discharged from the MDT care home, we will send out a MDT discharge letter, which outlines a summary of everything we've done and any actions or further recommendations. So again, I looked at lots of different models. We can often get very lost in what we're saying with these residents. So we just wanted something that was simple, that covered all the elements that are important. So we looked at the 5M model, which is a very simple framework, and it covers mind, mobility, medication, multi-complexity, and matters most. So ahead of time, the community matron will try and get as much of this information as possible, and there is subsections within that which covers weight, foot care, falls, bone health, advanced care planning, and we'll fill this in as we go along throughout the MDT. And the GP will get a copy of this at the end as well. So we feel by using this model, it does help us move towards a more holistic model rather than a very medicalised model. This is just a copy of our external referral form. So we wanted the process to be really easy, really simple, and to give GPs and care home managers whatever option is easiest for them. We know everybody is very busy, so if you are sitting there thinking you'd like to refer, you can either refer via your community matron, which hopefully you'll have all met, or directly to our MDT coordinator, either by email or phone. So this is just this slide is just a map of the process from start to finish, and in there we have our RAG rating. So we have, if we receive a large number of referrals, we will RAG rate them, so we can decide who we need to bring as in a priority. So we have red, amber, green, and within that is the criteria. So generally in the red criteria, when it was COVID times, we had COVID-19 residents, we have recurrent falls, increased confusion, recurrent hospital admissions, recurrent A&E attendances. And then in the amber section, we have change in behaviour, which is generally the largest number of referrals we would get. And then we added in the green because we wanted to give clinicians something that they could just, if they had a resident that fell outside that criteria, that they could just pick up the phone and could discuss it. So our activity, as you can see, it's going up. So we've been tracking it month by month. So this is a graph of our new referrals every month. So we started with 6 in the month of September, and we are now up to 29 as of last month. So we had 29 new referrals in April. And this is our caseload. So if we discuss someone, it's unlikely that we'll discharge them on the same day. It varies. We can have a resident on for a week to a couple of months. So similarly, we started with 6 and now we're holding 47 residents on our caseload. So some of the challenges, many we've learned as we've gone along, but I think the key ones to pull out are communication. So it's really difficult to communicate across organisations. We all know that it takes time. So us not all working on the same system is often problematic. But we are working on a process with that. So having the MDT coordinator who has oversight of generally what's going on has really helped. Building trust across the system. So, you know, we are a new team. We definitely struggled with engagement initially. We came in on the coattails of COVID. So we're, you know, not everybody is clear on what we're here for or what we're trying to achieve. And I think this will take time. So it takes time to build up these partnerships with care home managers and GPs. So that is something that is still a challenge and we'll continue to work on. And lastly, raising the profile of the care home. So as part of the wider health system, I think definitely it felt at the very beginning that, you know, care homes were not central to the discussions, but actually that's something we want to move towards. We want to place the care home managers and senior care staff who are advocating for the resident to be the ones representing them at these discussions. So risk, perceive or real, that they lack specialist knowledge. I have to say over the last few months we've had numerous care home managers join us, and I'm sure the rest of the team would say as well that their knowledge is so valuable. It's all in the details and it really matters with these patients. And cultivating a team ethos is a big challenge because it's not just one small team, it's many organisations, many providers. So big challenge, which we'll continue to work on. And this is just a bit of feedback. So our CLCH volunteers are currently seeking feedback in a more structured approach from our care home managers. So we'd love to hear their thoughts. We did get some feedback. I sent out a form to about 10 GPs, so I did get a little bit of feedback back. On the whole, it's pretty good. We still have areas to work on. I think we're a new team and we're still working through it, but if anyone has the feedback form in their inbox, please send it back to me. I'll leave that up there so anyone can have a look at it. And then if anyone has any questions, just let me know. And if not, I'll hand over to Dr. Gold for the case study.
Thanks, Louise. Gabby's posted in the chat, MDT has been very helpful. Is there any scope for contacting consultants for quick advice by email without doing a formal referral to the team?
I don't think we have scope for that at the moment. We only have a limited amount of time. We only have 4 hours a week, which is taken up for our MDT, but we are working on increasing the amount of time we have with the specialist services. So that potentially could be something in the future.
Okay, thanks, Louise. And Jonathan has a comment really about LAS refusing to send to hospital a patient, a care home patient who was vomiting for no reason. Because we did not know why she was vomiting, we insisted she went to hospital. She had new onset end-stage renal failure. Jonathan, do you want to add anything to that? Was that about a communication point with LAS or?
Well, I was actually there at the care home at the same time, so I was able to assess the patient and I knew her. And she had had blood tests a few weeks before and didn't have renal failure, and was very unwell. Rosemary, the manager, I think, is in the meeting as well. And LAS were insistent that because it was just vomiting, they didn't need to send her. But we couldn't manage her because she was still vomiting and we couldn't replace fluids and we didn't know why she was vomiting. So I insisted and she went into hospital, and I think, Rosemary, she died shortly after. But it's just that LAS, my experience with LAS is, in general, they're really, really good. But there is this feeling I have that they have instructions to try not to send people to hospital whenever possible. And that works a lot of the time, but you have to be a bit careful.
Yeah. Fair enough. Louise, I don't know whether you have any comments on that.
Yeah, no, I mean, I would agree. I think we are, ultimately, I guess it's admission avoidance, but safe admission avoidance. And we all, everyone on this call knows that these residents are really complex. And, if they need to go to hospital, then they absolutely go, So, yeah, it's difficult.
Yeah. Fine. Thanks for sharing that case, Jonathan. And just a couple of more questions before we hand over to the rest of the team, Louise. Arshna says, do you get tier 3 diabetes input for care home patients on insulin in the MDT?
No, we don't, but during the last wave, we did have 2 dietitians redeployed into the service temporarily. One of them was a diabetic dietitian, which was so good to have. And it's definitely something, if we stay, that we'd look to try and incorporate into our MDT. I mean, they still have the invite, and if it's in relation to a specific patient who has got problems with their diabetes, we could certainly invite them and see if they have time in their schedule to join.
Yeah. Okay, so kind of on an ad hoc basis. Thanks, Louise. And lastly, Prashant says, is the MDT here to stay? I mean, funding. Normally all good things come to an end.
Yeah, I don't have the answer to that, I'm afraid. I wish I did. I think the discussions are still ongoing. Obviously, I'm biased, so I would love it to stay, and have, really seen the benefits of it. But we have, a long way to go yet.
Yeah. Brilliant. Thanks, Louise. That's all the questions for now. That's lovely. Thanks.
Great. So what I might do is just ask Dr. Gold if she wouldn't mind coming in, and we've got 2 case studies, one from Dr. Gold and one from Dr. Romain and Dr. Levy. So I don't know if she's there.
Hi, yes, I'm here.
Hi.
Hi. Can everyone hear me?
Yeah.
Yeah.
Yes, we can.
So thank you very much for inviting me, Louise, and it's really nice to see lots of familiar faces and names. So it's I am loving being part of this team. I think it's excellent. I fully agree with the question of, is it going to continue? Because I think there's so much added value for our care home residents. It's a really, really important service that we're providing. And also going on from Gabby's question about can you email it? And I would love to be able to provide that, but psychiatry is only commissioned at the moment for one clinical session for the 90 care homes, which really isn't enough. So we would really love for it to be developed and commissioned further, and that's an ongoing conversation. So whatever we can do to provide support for these residents is really important. So our matrons have just brought, this is one of many cases that we discussed from a psychiatry perspective, and they, like Louise said, they're mainly, well, there's many reasons, but change of behaviour is one of them, and this is what this case presentation is about. So this chap was a 67-year-old man who was in the care home. Presented to us, there was some issues with regards to his blood pressure, drop from lying to standing, but the care home staff had noticed that he was very disinterested in all the activities and appeared quite low in mood. One of the advantages of me sitting in the care home meeting live with my Rio psychiatry notes is that I can kind of access what's been going on from a psychiatry perspective, which ordinarily the team wouldn't have access to. And we could see very clearly that he'd been seen by psychiatry before by Dr Gacquin, who had to prescribe risperidone in the context of challenging behaviour related to dementia, possibly delirium, anxiety and depression. So he came to the care home in May with various diagnoses from the hospital, and like you can see, past medical history of Korsakoff syndrome, vascular dementia, delirium, anxiety and depression, foot ulcers, AF, hypertension, and on a variety of medications here, some of physical health and some related to his mental health. So the sheet that the referral sheet is sent to me in advance of the meeting, so I have a chance to review it, and I was able to review it in cross-referencing the Rio notes, so I could see why and how he'd benefited from being on risperidone. Obviously, it's important that people aren't on antipsychotics if they don't need to be in care homes, but sometimes people do need to be. And we wondered whether this man had a change in behaviour because he was being oversedated by risperidone. So we tried to trim it down very, very gradually, so with the agreement of the care home staff. But unfortunately, as you can see, it kind of didn't go immediately well. We had a resurgence of challenging behaviour, which the care home staff found very difficult to manage safely for him and for other residents. He was aggressive, he was soiling around the care home area. So the GP increased medication back, and we went through kind of week on week in collaboration with the whole team, and specifically the matron, about adjusting the medication to get to the right balance. So I think in the end we found a kind of an optimum alternating days of 0.75 and 1 milligram of risperidone that worked for him. It meant that he actually didn't need someone from the psychiatry team to go out and see him. We were able to manage it remotely. But I think it's important to mention that there are people who do need to be seen face to face by psychiatry, and those people are triaged out by me and by the team in a full team discussion during the MDT, and those are still passed to the community mental health teams. So what we don't want is people to be disadvantaged by there only being one session for psychiatry. We want people to have as good a service as they would have done anyway, but there's many people who don't need to be on the books of the community mental health team, and we're managing very safely and effectively in this collaborative model. Always very happy to take calls from any of the GPs and email, so please be in touch if there's anything that you want to ask from a psychiatry perspective.
Thanks, Dr. Gold. I don't know if Dr. Levy is still there. I know he said he might have to go. So Mel, it might be yourself. Are you still there?
Dr. Mel's going to start talking. She'll be first. Can everyone hear us okay?
Yeah, we can hear you.
Yes, we can.
Hi, I'm Mel Rebane. I'm one of the geriatricians at Barnet. Briefly go through this case, and then I was just going to give a few other examples of how we think the care home MDT is useful, sort of from our perspective. So this case is a 72-year-old man living in a care home whose GP brought him to the MDT with a 10-day history of weakness, low mood, and sort of not eating and drinking as much. His background was that he'd had COVID last year, and also had a ileostomy for a previous diverticular operation. If we could go to the next slide, please, Louise.
Yeah.
The MDT And David Levy, who's here next to me, spoke to the treat team to be assessed in A&E or in the treat area for blood test and a scan. And the patient ended up being admitted and was found to have cholecystitis and was discharged much improved. And I think the point of discussing this case was to show that, of course, as we've said earlier in this meeting, the idea of the MDT is not to prevent all older people living in care homes from being admitted, obviously. And in this case, the patient did need to come in, but we were able to do it in a controlled way, which was planned rather than sort of as an emergency in the middle of the night, and resulted in a good outcome for him, I think. But the other sort of examples I just wanted to very briefly run through is that I suppose, so as we've said, we have a geriatrician present at all the MDTs, so it's a good way of getting quick geriatrician advice, and if patients do need to be seen, we can quite easily liaise with our hot treat clinic for somebody to come in, say that the next day, and have blood tests or a scan or whatever's necessary, and hopefully avoid an admission and get the right treatment. Another useful point that we have found is that we've got access to hospital notes and inpatient notes, which we can look at during the MDT. So in one recent example, there was a gentleman, a very frail patient, who kept aspirating and had recurrent admissions, and he was in a ward at the time, and the GP attended the MDT and said, they've had a lot of trouble speaking to the family about future plans and advanced care planning, and asked whether I could let the inpatient team know that. So I was able to do that, and the team had a long conversation with the family, armed with the knowledge that had been challenging in the past for the GP. In other cases, GPs have attended to talk about advanced care planning for somebody who's in a care home, and the GP had felt that the patient shouldn't have any future hospital admissions, but just wanted to discuss that in a team and have that sort of reassurance. And I think that's all I wanted to say about just our ability to kind of provide a liaison between the community, the GP, and the hospital, and hopefully do things in a more controlled way and prevent people having to languish or be admitted when they're more unwell as an emergency.
I was just going to finish off with a very short description of services at Barnet Hospital as we emerge from the year we've had with COVID. As you know, all of us went into the year in one way, and lots of us are emerging in a different shape. With the arrival of COVID, we also had the immediate delivery of a 35-bedded ward at Barnet Hospital, which gave us much needed additional capacity. And at the same time during the year, at Barnet was built a really excellent and superb 45-bedded hot floor next to A&E. In this hot floor, there is a 45-bedded area, but also 9 or 10 clinic rooms for us to provide hot clinic type activity. And in terms of the MDT, what we would like to do is to early on identify patients who are running into difficulty. Some of them just need discussion at the MDT, and we solve the problem in that way. But if there's a concern about a patient and, various tests have been done, but they're just not doing well, we can immediately bring them up to our hot clinics and assess them in a multidisciplinary way, rather than wait for them to continue deteriorating and then land up being admitted as an emergency. You probably have all heard the acronyms of TREAT and OPAU, Older Persons Assessment Unit, and etc. And all of these are really confusing acronyms. And from the 15th of May, we are going to be basically rebadging it all as a geriatric hot clinic, because it's sort of, at least says what it does on the tin. And we want patients to be referred to us from GPs, community matrons, care home managers, wherever, by a single point of contact. And we aim to offer same day care, or at least the next day. These clinics are not booked clinics, they're just completely empty. And so if you have a patient you're concerned about, just call us. If you phone Barnet Hospital and ask to be put through to the geriatrician in the hot clinic, they'll take the call, chat with you. They might be able to give advice and the patient doesn't need to be seen, but if the patient does need to be seen, they can be brought straight up. Just to finish off, the purpose of the 45-bedded ward area next to A&E means that no patients really have to sit in A&E anymore. The whole admitting teams of medicine, surgery, gynae sit in this assessment ward, and only the A&E staff are in A&E. Any patient who needs further assessment by one of these potentially admitting teams leaves A&E and is in this assessment area, and this assessment area is cleared within 24 hours so that there's a constant flow through it. And what has enabled that to happen is the additional 35 beds that were delivered with COVID. So I think if you have any patients who you feel need to be seen, just give us a call. You know, our elderly patients we see are getting ever older and frailer, and they just can't wait anymore 6 weeks for a booked clinic appointment. If they have a problem, they need to be seen now, and that's what we aim to provide. Obviously, some specialty clinics will continue to exist, like Parkinson's, continence, falls, etc. But for the run-of-the-mill sort of acute medical problem, we want to try and deliver same-day care. Thank you.
Brilliant. Thanks, David. That sounds like a great service, and agree with you. I think the fewer the acronyms, the better. And thanks to the whole team for your excellent presentations. Just in the interest of time, should we move on to some questions? So I think Barry had asked, what is the waiting time once a referral has been sent? Louise, I think you answered that. I think generally at the next meeting, which happens every Tuesday or Thursday. So pretty quick, Louise.
Yeah, pretty quick.
Excellent. Okay, brilliant. Karen Grossmark said, this is very useful. Is there any plan to help with housebound patients in a similar format?
Not currently. Sorry, I was going to say, not currently at the moment that we know of. We did support supported living with a lot of the COVID work, but not at the moment.
Okay, thanks for that, Louise. And then Arma says, do we know the impact of the service on unplanned hospital admissions since it started? I know you mentioned some LAS stats at the beginning, Louise.
Yeah, I mean, we are trying to gather as much data as possible. So we are measuring the A&E attendances in and out of hours. We're also recording other data such as residents taking off antipsychotic medication or dying in the preferred place of death. So we haven't collated it all just yet because we're still in the process of gathering it, but we're in the process of doing it. Okay,
brilliant. Thanks, Louise. And David Spitzer says, for practices or care homes closer to the Royal Free, should they be referring to this team at Barnet, or is there a similar service at the Royal Free?
I don't know if there is a service at the Royal Free.
It's treat clinics. I suspect it fulfills a similar role. Yeah, it hasn't developed in the same way as it has at Barnet. If I could just comment one step back about community dwelling frail elderly people. There is a separate community MDT that is run in one PCN in the borough of Barnet, one of 7. It's up PCN 6, maybe.
I think it might be, Anita says it might be PCN 2. Is that right, Anita? Anita says for housebound patients, PCN 2.
Yes, I've just put it in the chat. It's the PCN 2 has been piloting the MDT. And the good news is that the ICP has agreed to roll it out across Barnet in the future.
Brilliant. Oh, that's very positive news. Thanks, Anita. Louise Keane, thanks Louise, has said there's a hot clinic at the Royal Free for the homes, but that's in camp for the Camden practices only, I think. And then perhaps we'll take our last question from Tal. Will the referral fund to the MDT be on Bar Global? Is it possible to get the contact details for the MDT coordinator?
Yeah, I can send them to you, Anisha, after.
Amazing, thank you, Louise. I will circulate that to all the attendees after the meeting. That's great. I think in the interest of time, we'll look to wrap up now, unless there's any more burning questions. Huge thanks to all the care home team for taking time out of your day to be with us and to give us an update on your what sounds like an excellent service and a really positive thing for our elderly patients in Barnet. Thanks also to Charlotte and the Federation and our Training Hub members for the update. Just to say, before you leave, Emily is going to send out a quick poll to you. Please just fill it out just to say what your role is and how you value the meetings. It would be really helpful. It will take about 10 seconds to fill in, and it's really helpful to have that feedback. So Emily's posted the link to it in the chat. Please can you fill that out before you leave? And also there is quite a blank canvas for this year's Pan Barnet meetings. As you know, we plan to continue on the first Wednesday every month. If you have a learning need or a topic or a speaker that you have in mind that you think would be really useful for a Pan Barnet event, please can you you're welcome to post it in the chat, or please can you just drop me an email and I can look to timetable that in. Brilliant. Thanks everybody. Thank you so much for joining. Thanks again to Dr. Romain and Dr. Levy and Louise and Dr. Gold and the rest of the care home team who've joined us, and Kim. And thank you so much to everybody for logging on.
Thank you.
Thank you very much.